Yeah, so for patients who have estrogen receptor positive, HER2 negative breast cancer, that is the population enrolled in PALLAS, the standard of care is endocrine therapy for most patients, and that endocrine therapy could either consist of tamoxifen or an aromatase inhibitor, all with or without ovarian suppression, depending on the risk level and the menopausal status of the patient. And then we're learning about more and more about what is the role of chemotherapy. And in fact, at ASCO was additional follow-up of the MIND-ACT trial, which looked at whether molecular testing could help triage patients to receive chemotherapy or not. And the update really largely replicated what was seen in the earlier release of the MIND-ACT data, which is that for patients who have high clinical risk and low genomic risk, that those patients actually don't seem to benefit very much from chemotherapy, suggesting that the genomic categories are quite important. And interestingly, conversely, patients who had low clinical risk and high genomic risk also did not really seem to benefit tremendously from chemotherapy. So, that data, along with data that we've already seen using the Oncotype DX recurrence score, a different assay, really tell us that many patients, if not most patients with ER positive, HER2 negative breast cancer probably don't need chemotherapy. But the trick is, appropriately identifying and triaging the patients who do.